A very good afternoon, everyone. My name is Wong. I'm a medical oncologist at Peninsula Health, and I'm delighted to be moderating this afternoon's lunch live webinar on enhancing communication skills for telehealth delivery. This is an online edition from the Victorian COVID-19 Cancer Network, partnering with Cancer Council Victoria, and we're very excited to have more than 300 registrations for this afternoon's webinar. Before we start, I'd like to acknowledge the traditional custodians of the land on which the Victorian Comprehensive Cancer Centre, the Monash Partners Comprehensive Cancer Consortium, and the Cancer Council Victoria are located, and also to pay respects to the elders, past, present, and emerging, and to extend that respect to other Indigenous Australians present online. Next slide. The Victorian COVID-19 Cancer Network is a response to the challenges involved with managing cancer care amidst the current global health crisis with COVID-19. This joint initiative of the Victorian Comprehensive Cancer Centre and the Monash Partners Comprehensive Cancer Consortium aims to support and provide advice to clinicians treating patients with cancer during this pandemic. The network collaborates on a digital platform for professional discussion, information sharing, and peer support as the pandemic progresses, and there are specialized channels for various tumor streams and others, including clinical trials, telehealth, hematology, amongst others, for the purpose of problem sharing, sharing information, as well as support, as I've alluded to. Next slide. Just a quick overview of the upcoming online events that you might be interested. So please register your interest online in the website listed on the slide. There is also a Learn page for you to review past topics and webinars which have been recorded that you may not have been able to attend. All right, next slide. A quick housekeeping on how to ask questions. You can do so via the GoToWebinar platform, and please do so throughout the presentation, and we will answer your questions to the best of our ability at the end of the session. Next slide, please. All right, I might do a quick introduction on telehealth and COVID-19. The COVID-19 pandemic has certainly catalyzed the uptake of telehealth across many cancer services in Victoria and other parts of the country in the form of both video and of phone consultation in order to keep our patients home and to maintain social distancing and avoiding hospital visits. So this is further facilitated by the expansion of Medicare reimbursement items for telehealth consultation both at the general practitioner and at the specialist level, which currently runs till September 2020. It's probable that cancer clinics in the future would look different even beyond the pandemic, perhaps comprising of a combination of both telehealth and face-to-face consultation of varying proportions, depending on the locality and the practice specialty. Next slide, please. So whether it is now or into the future, it is really important and imperative for us to be able to deliver optimal patient care using a telehealth platform. And that's why we're here with the webinar today with three delightful speakers who will share with us some of their experience and gems on telehealth communication skills. Next slide, please. So at the end of this session, we hope that the webinar will help you, if not already, aware that effective communication skills in telehealth are important, and that's why many of you have signed up for the webinar, to also perhaps identify barriers to achieving effective communication and to identify some strategies to enhance our existing telehealth consultation skills. So we do have three delightful speakers for this afternoon, and without further ado, I'd like to invite our first speaker, Dr. Rob Campbell. So Rob is a general medical oncologist with an interest in most solid organ malignancies. He grew up in Bendigo and is passionate about patients getting access to treatment close to home. Rob has been working in Bendigo since 2018, and he also consults at Adjunct Regional Hospital and at Kerang District Health. He participates in regular telehealth clinics ran through the Swan Hill Hospital. And he previously completed his undergrad training at Monash University and undertook physician training at the Austin and Northern Hospitals in Melbourne, and subsequently went on to do his medical oncology training at Bendigo Health, Eastern Health, Monash, and Austin Health. This afternoon, we're delighted to have Rob to share with us some of his gems on communication over video through the voice of experience. Rob, please.
So my caveat to this is I'm not an academic expert in best conduct of telemedicine or telehealth. There's some people that have put lots of publications out beforehand, like Sarbe Sanderson, who's been leading this way for a number of years before the contraction in a number of areas due to the geography of Queensland. I'm also not an expert in medical law programming and what each technology's code or flaws are. So the things that I'll talk about are very practical approaches, but there may be things that can be used or not in a particular institution based on what their policies are. What I had here was just talking about the region that we cover from clinicians based in Bendigo, which is about 250 kilometres from our furthest clinic in the north to Kyneton down below. And obviously that's about 3 hours travelling. We have a vested interest in having telehealth work for our patients before COVID, during COVID and afterwards, because it's really part of our business as usual, or trying to become business as usual. Telehealth in our region, I'd say we're still relatively new to the game. We started our first telehealth clinic in 2018, and that was based in Swan Hill. And that was very much what I call a telehealth clinic model, where we have a nurse and the patient at one end in Swan Hill in a GP clinic, and we're based in Bendigo on a video connection. One of my colleagues then went on leave for 6 months, and so we had to increase our capacity to the region without having extra staff. We increased our clinic to fortnightly, and we started doing some ad hoc telehealth to regional hospitals. Last year, our telehealth increased further. One of our other clinicians has been doing telehealth once a month with a tutor, and we started doing telehealth to patients' home around that time. These structures that I sort of view telehealth as, which are probably applicable to all of you when you're thinking about having a telehealth clinic with either a patient or a nurse or etc., are the two ways I kind of view most of my telehealth consultations. I have a group of patients where it's a telehealth clinic, where there's a doctor based wherever in Bendigo, or they could be based in Melbourne, they could be based in a region, but they're based at one site. The patient at the other end is then not on their own. The patient has someone with them, whether that's a nurse practitioner, you could have a doctor. We've run it with nurses at the other end, but there are pros and cons of doing that. And the other way, which most people are running through the pandemic, is telehealth consultations to people at home. The advantages of the telehealth clinics we've found is that doctors love running telehealth clinics because they can be very time efficient. With nurses at the other end, people can get vital signs taken, print-offs can be given, pathology requests, CT scan requests, and also when the consultation finishes, there's a chance to debrief and make sure the information's retained. And if people are having chemotherapy, there can be a chance to book from there as well. Patients are generally happy with that experience we've found. The difficulty is it's a fairly rigid structure. You can't do this in ad hoc fashion. You need to plan ahead of time, and both sides need to be prepared for it. And it does put a significant impact on the person assisting the patient. So for example, when our chemo nurses are doing this from Swan Hill, that's time that they can't be doing giving chemotherapy or other patient care. The telehealth consultations where you have a clinician at home or a regional site and a patient at home has a number of advantages in that there's no travel for the patient. For clinicians, I find this a very satisfactory to work because I can put it in as a normal consultation wherever I'm working at the time. The difficulty I have with these consultations is often the IT infrastructure. I complain all the time about a hospital IT infrastructure, but at least I have someone I can talk to. When I'm trying to do a telehealth consultation at home, the patient's your telehealth, I see information support, and that can be really challenging trying to troubleshoot someone through a system over the phone when everyone's using different systems. I'm not going to cover the structure of telehealth clinics much further because I think that most people, particularly in a metropolitan site, this is probably not a practical model for most of you to be doing, although perhaps there are still ways if the pandemic was looking like it was going to take off further where you could do this through day oncologies. And I'd be happy for people to contact me separately if they wanted to discuss the structure of that. What I wanted to focus on, which is what most clinicians are doing now, is telehealth consultations, where you are a clinician at your workplace, at your home or wherever, and you have a patient then at the other end, probably at home. So we've been doing this for a while. From March last year to March this year, it's a small number of consultations. This is based on the data that our local integrated cancer services, LMICS, has been able to supply for us. There are some caveats. It only includes consultations over 5 minutes, and it only includes Health Direct, which is the hospital preferred program, whereas myself and a couple of other clinicians have used other programs from time to time. What we have seen though in the last 6 weeks is a huge increase, that in the last 6 weeks we had 498 video consultations lasting more than 5 minutes, and there are video consultations that were less than that or had to be changed to audio calls. When we look at that over the last year or so as a more graphic visualization, you can see that outside our telehealth clinics, which are not covered in this data, our telehealth to people's home was minimal really. Until the end of last year, we've started to try and increase that over time. But the types of numbers that we've seen in the last 6 weeks has been much higher than that. So the 50 patients that we saw over 12 months, we saw on one particular day, 54 patients in a day. So we've been having quite a high volume of video calls at patients' homes, not to mention at least double, if not double and a half of that of telephone calls. I just thought, as trying to speak with experience, the things that we have used is Health Direct, because that's a statewide preferred platform. But I find that not everyone can get that to work. We have used Skype, which has problems that the Russians may be able to spy on you through it, but it's something that people that have been using telephones or telehealth for some time or to speak to families can use. And the Cisco platform we really mainly use just for our end-to-end form. There isn't really a clear platform that you should use. I don't think any of them have a better communication strategy than others, but it's best having something that your hospital is comfortable with and you feel comfortable with. And various things such as FaceTime, WhatsApp, Zoom, Teams, and GoToMeeting like this can be used. The government actually doesn't regulate what you have to use. It's up to you. We've had our integrated cancer services try to get feedback from patients now that this is a much higher volume service, and we've had a survey of 41 patients from April, and what they found is that for people that went on the telehealth consultations, about 75% of them would like video consultations to be an ongoing option for appropriate appointments. You have to flip that and say that 20 to 25% of people don't want to do telehealth down the track. In this breakdown, it didn't really matter how old the patient was, what gender they were, what the treating clinician was. It all seemed fairly similar feedback across the board, which was interesting because I think a lot of clinicians have stereotypes about who could or couldn't participate satisfactorily in a telehealth consultation. So I think this is a fairly low issue, but about 17% of people had trouble setting up the appointment. And generally what we find is if the technology works, patients are happy. Satisfaction is about 4 out of 5. When there's major technical errors, it's bad. Patients, I'm surprised we get 2 out of 5 for satisfaction on that. They must just feel sorry for us. The categories of patients that when patients report to us where they have troubles with telehealth would be new patient appointments, when they're receiving bad news, and for patients who felt that a physical examination was necessary. I would couch that all of this feedback is where we haven't done this in a planned fashion. We've basically gone from face-to-face clinics to telehealth telephone overnight. So I do think that if you were to plan this more looking forward and you were to look at who you're going to do for telehealth, you may find that the feedback is a bit better when you choose who the first patients are, who you're going to give bad news to over telehealth. We did get general consensus that most patients found it convenient to have a video call within their home and not having to travel to appointment, and that there was still a good satisfaction with the rapport people will be able to get with the clinicians during the feedback. So my experience in the communication strategies around this, working with my peers, but also working with my patients that I look after, is that you need to have patients that are keen to do telehealth. If they're not keen to do telehealth, you can push that with them, but it can be a challenge to get the rapport that you're going to have. I think clinician buy-in is important. We've had some clinicians that have taken this up very proactively and a couple of other clinicians that have really struggled with the concept. And patients know whether you're comfortable with this. If you convey that you're uncomfortable with telehealth, that it's not business as usual, and that you're struggling with the infrastructure, when you're having sensitive discussions, patients will pick up on that and you'll struggle. I think it's important it's not a communication strategy, but you need to have clear pathways with admin and IT when you're having issues. So my feedback to clinicians and my peers when I talk about telehealth is that overwhelmingly you should just treat this like a normal consultation. You need to introduce yourself to the patient. You need to make time to build rapport during a consultation. You need to gauge what people's concerns are when you start the consultation, set an agenda. All of those normal rules still apply. It sounds very basic, but I have seen a number of colleagues get once you put the computer screen in front of them, a lot of the skills that they've had for years and years, they get uptight and nervous once you put a TV screen in front of them. I think it's really important from a communication point of view that you allow time for paperwork between patients. We've had a lot of support from our admin staff and our integrated cancer services in generating ways for our forms to be digitised, but these take longer and you need to allow time between patients. And when you've got patients that are waiting potentially for some period of time on the phone, or you're behind, that can be detrimental to the interaction that you have with the patient. I think it's also important you work with your administration teams and patient flow about how this is communicated. For example, we found that once we started doing telehealth, a lot of the bare necessities we needed for chemotherapy, height, weight, demographics, Medicare numbers, weren't being collected because patients weren't coming face to face. And now our admin staff are trying to connect with people on the telehealth consultation before we do, to get some of that stuff done before we proceed with the main conversation. I think it's really important that as a clinician, whether you're a doctor or a nurse, an allied health worker, that you're comfortable with the technology being used and you know a little bit how to troubleshoot it before you jump in the deep end, or you've got someone nearby that can help you. Because I think you being relaxed and comfortable during the consultation is critical for this working well. It's also important to look after your colleagues. I think that from a communication point of view, expect that there will be IT problems and be ready to change tack, whether you're stepping back to a phone call or for some patients where it's very difficult arranging a face-to-face consultation. Interestingly, the feedback that we've generated is that it actually seems that the clinician comfort around telehealth is a bigger factor than patients. Patients can be brought into telehealth if they have a good relationship with their doctors, nurses, and they're often willing to go with that if you have confidence and can talk them through it. When clinicians are uncomfortable, they're going to struggle. One of the biggest feedbacks I have, I have to reflect on myself when I talk to my peers about, is beware of your blind spots. So in a telehealth consultation, there are things that you can't do that you do in a face-to-face. You can't check people's vital signs, which can be very helpful. You can't examine patients easily. Having said that, there are workarounds. Some of my telehealth patients are pretty obsessed, and they have their own blood pressure monitoring, glucose monitoring, and they take more vital signs than I sometimes do when they come in face-to-face. The other thing which I sometimes try and employ is if people are on medications and they don't know what they are, don't stop the video call. Don't try and call them afterwards. Get them to go get it during the video call, and you'll get some information about what their gate's like, how long does it take them to get to the kitchen and back, how well do they navigate furniture. There are a few things that you can pick up even if you're not doing a face-to-face examination. I think going forward, the way I will use telehealth is quite different to some of my colleagues in Melbourne. Realistically, you're going to be restricted by unless you're going to do telehealth, which is unfunded, you're going to be restricted by what the government does from a regulation point of view. Telehealth areas in the regions, I think, is going to be enhancing your practice rather than replacing your practice. I wouldn't be using telehealth for most people to replace my face-to-face interactions in the longer term, or examining people, but there are a number of people where geography is difficult, and there is a bit of a scale between how important it is to see someone face to face versus how far they're travelling. And I think it's important to be open with that with patients and trying to come up with a mutually acceptable solution. For example, there are some patients who you're doing oral titration of opioids. They're starting oral-based treatments, and in fact, a telehealth consultation may be all that you need for the first 2, 3, or 4 visits before they come back face-to-face. If you're doing treatments for people that are coming 100 kilometres to your infusion centre, I think it's a great idea to telehealth them the day before. It may not replace having to see them on the day, but it will. There are a number of patients where you'll know the day before whether you're going to have to not proceed with treatment and cancel from there. So they're just some of the things where I would think about if, for the rest of my colleagues who aren't as comfortable with telehealth. There are a few times where I think telehealth as being a preferred option is not ideal. People with significant hearing impairments often struggle with telephones and telehealth infrastructure. People that have a struggle with dexterity, with significant rheumatoid arthritis struggle. Language barriers can be very difficult to manage over the phone, although I have seen this done before. And if you've got internet access issues that can't easily be overcome, then you need to have a backup plan. And if I know ahead of time someone's going to need an examination, then I will try not to make it a telehealth. So that were just my reflections before. Again, I don't profess to be an expert in all aspects, but I'm happy to be asked directly or to give other feedback where people find it helpful. Thank you.
Thanks very much, Rob. That was a very comprehensive account of your experience, certainly valuable for our listeners to the webinar. We might keep the questions to the end. I'd like to introduce our second speaker, Ms. Kate Barber. So Kate has been a registered nurse for over 30 years and has worked both in the public, private, and not-for-profit sectors. She has worked as an associate nurse manager and a clinical nurse specialist in surgical and medical oncology, as well as in palliative care. And she's passionate about supporting and advocating for anyone affected by a cancer diagnosis. So Kate has worked at the Cancer Council Victoria on their 13 11 20 hotline information and support telephone service since 2018, and loved the scope and opportunity this role provides for interacting with callers, listening to their stories, and the scope of the discussion, as well as the opportunity that the role provides support for the patient at the end of the line. She was awarded a scholarship from the Cancer Council Victoria to attend the communication skills retreat in 2019, which she found to be an excellent opportunity for development of communication skills. Kate also has a diploma in counselling and runs her own counselling private practice. And while offering general counselling, her business has a specific focus on providing counselling for anyone affected by a cancer diagnosis, including patients, their significant others, health professionals, and the wider community. And today, Kate will share with us her experience and her expertise on communication over the phone. Kate, please.
Thank you, Zee. Can you hear me okay?
Yes.
Can you hear me?
Yes, we can hear you, Kate.
Great, thank you. Thanks, Zee, and thanks for having me today here as part of the panel. As Zee explained, I work for Cancer Council. Cancer Council, for those that of you aren't aware, have run a information support phone line for over 20 years now, offering direct support to people affected by cancer. Also, we get calls from carers. We have calls from health professionals and also the general public. So it's certainly a medium that we're very used to, and it's something that we've really noticed an increased demand for during this COVID pandemic. And we've been also supporting the sector with partnership with Peter Mac as part of their on-hold messaging, as they've found a huge increase in the amount of calls to their line as well. So firstly, I just wanted to highlight that there are quite a lot of advantages to telephone telehealth. It's been a medium that has been used for many years, and obviously we've seen a huge rise in it with the challenges we've been facing with COVID. And the greatest benefit would be that it's a very well-known medium. We're all very, very well versed at talking on the phone, some of us better than others. And yeah, whether it's through smartphones, landlines or payphones, most people will have access to a phone at some point. People are able to choose the location from which they call. It can be the comfort of their own homes. It can be anywhere really that suits them. And there's no travel involved, which is really beneficial for the elderly. People with a disability that might find it a little bit difficult to get out, and those who are too unwell to travel. As Rob has mentioned, also regional and rural callers benefit, and of course people who are isolated as well, especially with the pandemic. Although we do always confirm identity, there is a sense over the phone of being an anonymous caller at the end of the line. And one thing that we've found is that it really does allow for disclosure, and that might not occur in other settings. And further to that, there is less fear of that stigmatism or judgment too. This can be particularly relevant for chronic health management, and also an issue for some people with cancer who've had treatment that has resulted in disfigurement. As with any communication medium with telehealth, there is some challenges as well. You know, what Rob was pointing out is that there's no scope at all to do any physical assessment or see someone's physical space that they're in. But probably the most obvious one with telephone telehealth is that we don't have access to any visual or non-verbal clues that we would normally, you know, take on and see from whoever we're talking to. Everything that we're working on has to be through that phone line. Environment, we don't know what's going on in that call. The attention may be divided in tricky conversations. And we have found too that people can be nervous with this type of communication. They're really used to seeing their healthcare professionals face to face, and you know, as we all know, everything has changed for a lot of people, having to change the way they see their healthcare professionals. They all know that connectivity, and it's no different from a telephone as well. There are some issues with phone connection as well that can be impacting on calls that we have. And
apologies for the little technical challenge we have there. We might move to the third speaker first. Before going back to Kate, we're trying to fix the connection issue over there. So our third speaker is Professor Peter Martin, who is a professor of clinical communications and end-of-life care at the Deakin University School of Medicine. He's also the director at the Center for Organizational Change in Person-Centered Healthcare at Deakin University, Faculty of Health. Peter is a palliative medicine physician at Bowen Health. He has been involved in communication skills training for more than 2 decades and has been a clinician for over 30 years, with his clinical interests being in cachexia. Peter has taught communication skills with Cambridge, Monash, Melbourne, and Deakin medical schools, and has also been involved in numerous postgraduate courses with a variety of health professional disciplines nationally over the last 15 years or so. Since becoming the director at the Center for Organizational Change in Person-Centered Healthcare, Peter has helped develop and run numerous courses in healthcare communication, including Train the Trainer courses, and amongst others. And the center itself's major intervention is an organizational level intervention to drive person-centered healthcare communication called Your Thoughts Matter. And today, Peter will share with us some of the skills and tips on communication so that we can implement in our practice when doing telehealth consultation. Peter, please.
All right. So I was just saying that I have my own experience in telehealth, having run a clinic for a number of years with a telehealth model that became much bigger over the last number of months, where we actually have 4 different people, 4 different clinicians and the patient and their families. But I'm really going to focus on the communication skills that are key in telehealth. I just wanted to say, here's a UK consensus guideline around communication skills, and you can see this comment that although the focus has been electronic health records, there is a real concern that that's not something that's formally taught. And you can see over here in these circles all the methods, so telephone that Kate was just talking about, written, face-to-face, electronic health records, and this idea of digital or telehealth. One of the themes that hopefully you'll see keep coming back is that it's really important to invest in the beginning and create rapport despite the change in technology. I'll come back to about the patient's perspective, the place of empathy, and the importance of closing up formally. There's also this model, the Calgary-Cambridge model, which is about key structuring skills and the phases and how you build a relationship, and they're just as applicable in telehealth. In fact, some of them become much more important, and that's what I'm going to focus on today. So I'm going to break it up into these 5 chunks: rapport building skills, information gathering skills, structuring skills and time efficiency, the importance of nonverbal, and this is probably the biggest issue in telehealth, and aiding recall and clarifying next steps. So building rapport and information gathering, which I'm going to put together. And I guess if there's one slide that I want you to pay attention to, it would be this one, that the key micro skills that I see in telehealth from my colleagues are that people forget to pause. The evidence is that it's a 3 to 5 second pause that allows people to ask you to clarify your comments or questions, allows other people to speak. And in general, you need to slow down, particularly in telehealth. And that's even more the case when you're providing information rather than giving information. I'm going to talk about questioning styles in a minute and the importance of verbally showing empathy when you're doing telehealth, because the non-verbals are lost a bit over the technology, even with the best of technology. Being very careful about your active listening, that you get very easy to get distracted with a number of layers, and so not just thinking of the next question in your head or paying attention, because you'll miss vital verbal or non-verbal cues. To develop an early shared agenda with the patient. This is what I would like to discuss. What would you like to discuss? Right, we've got 10 or 15 minutes. Let's see what we can cover today. But do that right up front, and I'll come back to why that's so important in a minute. And what we know from the literature is that we tend to focus on our own go-to areas. So as a palliative care doctor, that might be pain. As a radiation therapist, it might be something else. We all have things that we go to, but we know from the literature that we avoid a lot of the things that are important to our community. And in fact, the figures are that we miss them about 80% of the time. I just want to say that here's an article from the Mayo Clinic. And the big problem with this is that we still interrupt patients. And in fact, this is an outpatient clinic where in this case, the doctor interrupted the patient after 11 seconds. And so that really gets in the way of allowing the patient to say what they want to talk about, and obviously has a real issue on rapport. The next thing I want to say is back to this idea of us going to our disease elements, which obviously are vital, and I'm not suggesting you'd stop it, but what we know from the literature is that clinicians that can weave between disease and illness, and this is this idea of what they think is going on, what they're worried about, and what impact it's having on them, and of course the emotions that arise. And that can be different in people with different health literacy levels. I just want to put this up. I showed this last week in the last webinar, but often people ask the big questions when you ask them what they want to talk about, and then you pause at the start of your telehealth consultation. So just saying what's important for you today to talk about, and then doing that big pause. It's often the time they'll ask you a big question that's really important for them. In terms of question styles, you may not have thought about your question styles, but ones that I think become very important in telehealth are those kind of prioritized ones. What's the most important thing to talk about? What else is happening for you? The screening questions, or sometimes some of those kind of reflective or clarifying questions. So just think about, because we know we often ask a lot of kind of closed questions one after the other often. So structuring skills and time efficiency. This is even more important when you're doing it one-to-one, certainly face-to-face. And in my clinic, where we've got a physiotherapist in one kind of screen, a dietitian in another, a nurse in another, etc., it becomes even more important. So you need to signpost. We're going to speak with me for 5 minutes, then you're going to speak to Kate, the dietitian, then you're going to speak to Meg, the nurse, then you're going to speak to Matt, the physiotherapist. So you need to be absolutely explicit. And also signposting, we tend to speak about what content you're going to discuss. Can we spend this amount of time, then check your logs, then discuss that? And of course, the other key structuring skills are summaries, but there are actually key elements to them. Preface your summary. I just want to make sure we're on the same page, but can you correct me if I get anything wrong? I'm hearing you've had chest pain for 4 hours. Then you had shortness of breath, and you need to pause between those points so they can clarify or correct you. and either conclude with, let's talk about this next, what would you like to talk next, or just pause and see what that summary has brought up. And those are probably the two of the key skills that you need to pay attention to. In terms of your time efficiency, the literature is very clear that the irony is that by building rapport, getting that agenda early, and spotting and responding to cues of verbal and non-verbal, and of course with telehealth, the non-verbals become much trickier, you actually shorten consultations. So a little bit about non-verbal. The cues are really important, and what we do know is that you probably need to think about your framing of your picture and what that means in terms of being able to see your facial expression, eye contact, and particularly if you've got an electronic health record as well. So thanks for telling me that. I'm just going to turn away and write that down in my notes. I'll be back with you in 1 second, rather than just turning away when they might not know that what you're doing. Some early research that some of my colleagues have done overseas is that the eye contact is particularly important in the first few minutes of the consultation when they've used eye tracking software. So here's an old paper to say that we miss most cues, and this is even face-to-face, but if you spot them and respond to them, you shorten your consultation. So just to say it's really important for them and for you. Here's another one about the tone of your voice. And all I want to say about that is that your tone and how approachable you are really matters. In this case, it was studied about how likely you are to get sued. But I'm just getting to the point that your tone when you're using these sort of technology becomes even more important. So recall, this is about teach back, and the idea that at the end of your session, you want to be really careful that they've got it. So the teach back, which is predominantly a nurse, in the nursing academic world, is now we've gone through that, would you mind recapping what we've covered together? And this allows you to see what they've got and understood and what they may have missed and that you may need to add to. So I'm sorry that's such a quick gallop through such an important topic. I've certainly found I've learned a lot about my own comm skills doing consultations over telehealth, and I think it is here to stay, and we need to really think about where it fits in professional development and education. Thanks very much.
Thanks very much, Peter. We'll now have Kate back to continue from part of a talk. So again, once again, our apologies for the challenges we have. Probably heavy internet traffic at this time. Kate, take it away.
Thank you, Z. I'm back. And I can't see anything, but I can talk. So that's what we're all about, is working about the telephone. So I'll just go back a little bit to talk about what we're aiming for on our telephone calls. So I think I'm probably repeating a little bit here to what Peter just said. What we're aiming for especially is we're talking about establishing that rapport and warmth, which is really important at the start, which helps that therapeutic relationship. We don't have those visual cues to screen for distress, and I think probably all of us have experienced at some point or another a time when the initial reason that someone has come in for a consultation or a phone call in this stage, what they've said is the most pressing concern. When we establish what's actually going on with them, there are other immediate health concerns or mental health concerns that need to be addressed as a priority. So we might need to, rejig what we're planning in that call. We're aiming for succinct information, as Peter just said too, so that the caller can then recall and understand what has been said to them. And we're also obviously wanting privacy and confidentiality. We want the caller and the healthcare professional to come away feeling that the interaction was satisfactory, that the caller got something out of it, but also the healthcare worker did as well, so that that was a satisfactory interaction. And we want to also ensure that we've instigated appropriate referral and follow-up from the phone call. There are a few specific things to consider. I think, I'm just going back a little bit here, but certainly appointment reminders are important if you're doing appointments over the phone. People aren't really used to having their appointment with a healthcare practitioner over the phone, so sending those SMS reminders is important. The timing of the call is really important, especially from the healthcare practitioner's point of you. Have you got time to take that call? You know, there's no point making an appointment time if you've got to rush off to another meeting or something. So thinking about time constraints and how effective that's going to be, that call. You might have had no previous contact. So as we've all said, I think today, taking that time to establish rapport and getting that comfort level at the start of the call. And like I've just mentioned too, caller safety is really important. Distress screening, and establishing state of mind early in the call will ensure that both you know, the caller is safe and that you on the other end of the line are able to offer the most appropriate and timely support. The use of interpreters, the TOS interpreter service is always available, and if there is a language barrier there, certainly consider using an interpreter. And assessment of the context of the call, what's going on? Can you hear a lot of background noise that might make hearing difficult? Is the caller in the car? I know we certainly get a lot of callers ringing in from their cars. And especially at the moment with COVID, where there's kids being homeschooled, there's other people in the house that might be doing uni from home or working from home, and also the pets. We've certainly seen a lot of pets on these mediums as well, and other distractions that are going on. I just wanted to also mention in that sense the use of speakerphone and extra landlines. This in itself can be really challenging. We do find quite often that will be put on speakerphone, and that's fine. And we all know that sometimes it's really great benefit to have another person in the appointment. In the phone situation, we do just really need to be mindful of confidentiality and what is discussed. If it's delivering bad news or some such sensitive information, we might need to think about rescheduling that call. And it's good to expect the unexpected. We certainly get a lot of people that have to get off the phone quickly, and or there's other interruptions which affects that phone call. And then talking about ending the call, summarise what you've said, have the caller repeat that back to you so that you know that what you've conveyed is what they've understood. And any form of follow-up, and that may be in the form of a callback, an email outlining what the discussion was about, or posting out any sort of information that might be beneficial. So I suppose when we're talking about enhancing communication, and Peter has touched on this also, research has shown that 22% of our communication is through the tone that we use. And just as Peter said, that warmth coming out through your tone, it does come through the phone line, and a lot can be conveyed through the tone of your voice. And certainly not underestimating smiling on the phone. You can actually hear when someone's smiling on the phone and making expressions. It does get conveyed through the phone line. Giving the person on the other end, you know, the space and the time to disclose what they need to disclose. Use of silence. It can feel a little bit awkward when you can't see the person face to face, but it can be really effective in letting someone on the other end of the phone just get their thoughts together about what they want to express to you. Obviously, the use of open-ended questions to elicit information and closed questions to get specific information. And certainly talking slowly and clearly, not overwhelming with a lot of information. As we've seen today perfectly, sometimes the lines aren't that good, so we need to make sure that we get the desired information across very clearly. Quite often on the phone, we can get quite a lot of high emotion, and just sitting with that is okay. And also clarifying with the person, you know, quite often what we may hear is anger. We might hear that someone's angry, clarifying that, asking them, you know, I can hear that you're sounding really angry there. And they might just say, well, actually, no, I'm not angry. I'm just frustrated at this situation. So clarifying is really important, so you're both on the same page. And like we've mentioned too, when you're giving specific information, encourage the caller to repeat it back to you, and also to write things down so they've got that for future reference. Summarising and outlining what the follow-up is going to be for them, so they know what's happening and you know what's happening. And of course, documentation is the same as it always is, thorough documentation and confidentiality. And lastly, telehealth can be exhausting. I think we've all found, you know, sitting in front of computers and talking a lot, especially with us here on the phone, we've found a huge increase in the calls, and that's exhausting, doing a lot of that telehealth. Rewarding, but it can be overwhelming at times. So it's really important to be mindful of your own self-care. This may be just between calls or between any sort of telehealth, taking a little bit of time out, even if it's just to go and get a cup of tea, have a little break. And, you know, when you've got appointments back to back or calls back to back with that rapid fire, it's really important to, you know, take a little bit of time out for yourself. So you're doing the best that you can in your job, because that's what we're all really wanting to do. Reviewing your process as well and assessing how the call went. You know, some of these platforms are new to a lot of us. So we want to give the best care that we possibly can with this new sort of technology. Not that phone is new, but other, you know, people might not be familiar with the telehealth idea. So it's really important that we review how our calls go, how was it, what we did really well, what didn't work perhaps so well. And, you know, as Rob mentioned earlier, some conversations aren't appropriate to have over the phone, and that's when you would change the type of medium that you're going to use. And debriefing with your colleagues, sharing some tips like we're doing today, sharing tips, supporting each other while we're all navigating through COVID and telehealth. And, you know, it seems that it's offered a great deal of flexibility in terms of how we deliver care, which hopefully will continue on into the future. And like I said, 13 11 20, run by nurses, and anyone is welcome to give us a call at any time. Thank you so much.
Thanks very much, Kate.
Thanks, Dee.
You finally got it working. Great job.
Yeah.
I'd like to this time invite the panel so that we can answer some of the questions that have come through. All right, so we've got a couple of questions. The first one, can you tell me who would be the academic expert on telehealth in cancer? I wonder if anyone wants to take that question. Yes, Peter. We can't hear you, Peter. I think are you muted? Can we unmute everyone, please?
Thank you. Sorry, I was muted and couldn't unmute myself. I've just put a link into the oncologist that Rod mentioned earlier on an article that he wrote in the MJA survey, who I don't know, and there are others worldwide. So I'll try and share. I have to say, most of the literature that I'm aware of has looked at the electronic health record and the impact, particularly in the US. And there's been some good studies on the communication style. And there's people who have looked at telehealth and teleoncology. The bridge between the two has not always been as well formed. There's been a lot on the technical aspects rather than the communication aspects. So I think it's great that Salve's, you know, tried to address that with the article that I've posted, and hopefully the organisers will share that. So I'll pause there.
All right, thanks, Peter. The second question is probably, Kate, you could take that one. How many phone support workers are there at the Cancer Council? Has there been an increase during this period of time? Can you hear me, Kate? Yeah, I think you're muted, Kate.
There we go. That's it.
Yeah.
So there's about 13 nurses at 13 11 20. On any given day, we might have 4 to 6 nurses on the line. 6 is a good day. We're happy when we've got 6 nurses on the line. We have seen, especially at the start of the pandemic, we saw a huge increase in the amount of calls that we were getting. Last month, for example, we went up to 154 calls for the week. That was, you know, usually we sit around 100 perhaps calls for the week. So there was definitely a lot of anxiety early on around the effects of COVID on our cancer patients. It has gone back to a sort of a more, I suppose, what we would call a normal level of calls now. And COVID seems to have taken a bit of a back step in what the calls are about. But we are starting to see a little bit of an increase in people's anxiety about getting back into the community now the restrictions are being loosened, and what the implications are for that for our cancer patients, especially those patients having treatment.
Sure, thanks, Kate. Now, there are quite a few questions coming in very quickly. I'm just conscious of time. We do have a couple of minutes. This other question from the audience. Does anyone have a virtual waiting room for urgent symptom review where patients can self-book appointment? Not sure if Rob, you want to take that one?
Yeah, I'm happy to take that one. We don't have that, but the way I'd approach telehealth is not to do something different with telehealth around your standard practices. So I think the way I would approach that question is, do you have an urgent review clinic where people can self-book? And if you do have that, then you should use your existing strategies around that and make those appointments telehealth where appropriate. I think that would be a much better way to incorporate that into your practice rather than trying to build a new waiting room for that. I think that most centres will have really well-defined structures for this, and I would just be trying to use telehealth to augment that rather than start from scratch. But certainly, if you're looking to expand your service down the track, you could do that.
Yeah. Now we might take one last question, and I'll open that to the panel. What tips do you have for interpreters through telehealth consultation, whether it's via phone or video?
So I'm happy to take a little bit of that. So the first thing is, we know from the research is that they tend to translate the biomedical accurately, but not some of the empathic comments so accurately. So you need to be careful that what you may think is empathic. You need to actually use your non-verbal skills even more with interpreters. So that's a real issue. And the second tip I would have is to give the interpreters very small chunks, pause, let them translate, and look at the non-verbal response you get from the patients or family members. And I know the Cancer Council did a project where they recorded what was interpreted and then got it independently translated. So there's some very good evidence about what happens. And I think the only other question I saw is about how you tell big news over the phone. And I would suggest the simplest tip is to give them a warning shot. I've got something serious to say. Pause. Is this an okay time to say it? Pause. Is there somebody you'd rather with you? Pause. Those three checks are probably the single biggest issue about complaints. And I've studied the complaint literature about why people complain about being told serious news. So just checking in that they're ready to prepare themselves, they've got an opportunity to have a support person, I think are the top tips that I saw from a nurse who said, how do you do this over the phone or telehealth?
Sure. All right, I'd like to thank our three panelists, for taking time out to share with us your experience on communication skills during telehealth consultation. I might just ask Erin to share the key messages from the webinar, and a lot of them actually have been discussed in details. I thought this will be a quick take-home messages for the audience listening in. The mindset is really important to continue to practice compassion and empathy, which Peter has taught through, to be able to establish that rapport and take extra time to maintain eye contact, as he's alluded to, and the technology aspect of things to make sure that the audio and the computer works well, which is what we experience real time here, and of course the internet traffic. And being aware of the need to maintain privacy, in a quiet surrounding, both your patient and yourself, and to confirm the identity of the patient early for consultations whereby you may or may not be familiar with the patient in the first instance. And we can't actually emphasize the importance of speaking slowly, as Peter has shared with us, the teach back technique, so checking back with the patient, understanding and summarizing and going back. And finally, he spoke to us about, breaking bad news. It's possible to do that over telehealth. May not be as good as face-to-face, but using some of the techniques to do that. And that will be really valuable. Now, I just like to wrap up the webinar to thank our speakers again for really taking time off and sharing with us, and also like to thank the incredible team at VCCC and at Cancer Council Victoria, both at IT and admin, without whom this webinar would not have been possible. I'd like to quickly just show the last slide. There is a community of practice for telehealth that you can jump online at telehealthvictoria.org.au. And there are some valuable resources such as online module for end-of-life conversations, effective cancer communication training programs, and an advanced communication skills retreat, which is planned for March 2021. Thanks everyone for joining in this Launch Live webinar, and we look forward to you joining us again on the coming sessions. Thanks very much.